Good evening, everyone, and welcome to Mahamana Case Discussion Series. For today's session, we have Dr. Mitali Lall, and she will be presenting on patterns of spread in maxillary cancers and its surgical implications. Dr. Mitali is a chief consultant and head neck surgeon at Paras Health, Patna. Welcome, madam.
Yeah, very good evening, Aseem, and very good evening to everyone who's logged in. A very interesting topic actually for discussion, and I hope I'm able to do justice to it. So, maxilla per se is quite unique. Why? In terms of the varied histologies which can affect the maxillary sinus with regards its cancer. It can range from very benign looking hamartomas to very ominous or high risk sinonasal undifferentiated carcinomas, adenoid cystic CA, apart from the other multiple histologies. Not just that, there are several inflammatory lesions like a typical fungal sinusitis also that can mimic tumors, and hence diagnosis per se is challenging. Uh, what is also unique is the fact that these different histologies have their different characteristics. Like we know, adenoid cystic CA is known to have its propensity for neural spread, and hence its treatment by and large is also driven by the kind of histology that we encounter. Apart from that, there are other several chemosensitive histologies like high-grade tumors, the neuroendocrine carcinomas, some rhabdomyosarcomas, which respond dramatically to chemotherapy, and hence probably that would be the first line of management in these cancers. The point I'm trying to make is a maxilla has a lot of inflammatory lesions as well as varied histologies which can affect it. And that has a bearing on the kind of treatment that one plans. Uh, what is again interesting is the fact that apart from the varying histologies that one encounters, this by itself is a very rare cancer as opposed to the very common oral squamous cell carcinoma that we see in our everyday clinic. Paranasal sinuses tumors are rare. Uh, it is affected by various histologies. Thankfully, maxilla is the most common site where we encounter the paranasal sinus cancers. Now, the maxillary bone per se has the sinus, which forms the major part of the bone. Apart from that, it has four processes. One extending superiorly to the frontal bone, that is a frontal process. Inferiorly, it has the palatine process along with the alveolar process. And laterally, there is the zygomatic process that makes up the maxillary bone. Maxilla per se has a direct extension via its bony margins. In addition, there are a lot of foramina which have a neurovasculature passing through it and thus has a bearing on the relations that the maxilla has with the various surrounding adjacent structures. Now let's take one thing at a time. Let's go to direct extension. Anteriorly, very obviously, maxilla has the anterior bony wall, which anterior to which lies the soft tissues of the cheek and the infraorbital foramen. Typically, such patients come with facial swelling, ulceration, frank ulceration on the cheek, or also paresthesias. Medially, very obviously, it has the medial wall with its connections or relations to the nasal cavity. This causes, in addition to the lacrimal apparatus, and these patients typically come with nasal obstruction, they come with epistaxis. Affection of the lacrimal apparatus in the form of the nasolacrimal duct can also result into epiphora as a presenting symptom. Now, superiorly and superiorly there is the orbit with its various connections, including the orbital, the entire orbital walls and the fissures as well as the canal. the optic canal, which harbors obviously the optic nerve, superior orbital fissure, as well as the inferior orbital fissure, apart from the lacrimal gland and the nasolacrimal apparatus. So affection of direct extension into the orbit obviously causes proptosis, diplopia, epiphora, apart from very severe cases where there is loss of vision. Superomedially, there are connections to the various sinuses, and higher up, it has the connection to the anterior cranial fossa. And thus, apart from the sinuses, there could be severe symptoms of neurological deficits in very advanced cases. Inferiorly, it is related to the palate and the teeth, and these patients typically have loosening of teeth, oroantral fistula, or palatal mass. Now, posteriorly, again, the maxilla has relations to via the retroantral fat pad into the masticator space and the pterygopalatine fossa. Extension into this space causes trismus, neurological deficit because of the various neurological connections. Also, interestingly, if one recalls, the retroantral fat pad continues via the posterior buccal mucosa into the buccal space as well. So extension of maxillary tumors, cancers can occur into the buccal space via the retroantral fat pad. Then coming on to neural relations, there are several foramina into the maxilla through which the tumor can escape, particularly if you're dealing with something like adenoid cystic, which has a propensity for perineural invasion. Inferiorly, we have the palatine nerves, the greater as well as the lesser palatine nerves, which causes palatine anesthesia, and also anteriorly the nasopalatine nerve, which causes palatine anesthesia if affected. Now, if one sees this axial cut of the CT scan very closely, higher up into the higher up the maxilla, one encounters something called as a pterygopalatine fissure, through which there is a relation to the pterygopalatine fossa. Now, why is it interesting? It is interesting because the main content of this pterygopalatine fossa is the pterygopalatine ganglion. And this has relations to the orbit via the zygomatic nerve through the pterygopalatine nerves. It has relations to the maxilla per se via the maxillary nerve through the infraorbital nerve. It has relations to the nasal cavity per se via the nasopalatine nerve as well as the pharyngeal canal, as well as we saw, relations to the oral cavity via the palate. Now, this foramen, the maxillary nerve exits from the foramen rotundum, and it has relations to the pterygopalatine ganglion. Again, in addition to that, if you see this diagram closely, the pterygopalatine ganglion also has relations with the facial nerve. The facial nerve via the greater superficial petrosal nerve and its connections with the deep petrosal nerve form something called as a Vidian nerve. Now, this has a relay to the pterygopalatine ganglion. The reason why I'm stressing upon all these nerves is, we'll come to it in a couple of slides. If you look at this coronal cut closely, the Vidian canal is superolateral and very close to the skull base, particularly to the orbital apex. And as you can see, anteromedial to it lies the foramen rotundum, the one which through which the maxillary nerve passes. Any affection, particularly of the Vidian canal, by and large, is an indication of high pterygopalatine fossa involvement, and it gives us an indication of unresectability. Now, how does one know clinically whether we are dealing with something related to the Vidian canal? It is a very subtle indicator, but something which needs to be understood at the back of our mind. As opposed to the other nerves, when the Vidian nerve or via the greater superficial petrosal nerve and the deep petrosal nerve is involved, The patient classically tells us about decreased or absent lacrimation, nasal dryness, dryness of the palate, in addition to obviously the paresthesias that he encounters on the face. So this is a very subtle clinical understanding of whether we are dealing with a resectable or an unresectable tumor. Needless to say, any affection of a tumor as high as that would reasonably result into trismus, unless you're dealing with something like adenoid cystic, which subtly escapes through the perineural invasion without causing significant trismus. So, as we saw in the previous slides, there are close relations to the orbit, and extensive invasion into the orbital apex is a sign of unresectability. Escape into the middle cranial fossa or gross brain infiltration is a sign of unresectability. Involvement of cranial nerves apart from the maxillary nerve is an unresectable cancer, apart from obviously involvement of the nasopharynx or the clivus. Now, in order to make a surgical judgment as to whether resectable cancers are amenable to endoscopic or open approaches, again, there are certain criteria. Let's look at what kind of tumors would be amenable to endoscopic resection. This is a very large study which actually sets the benchmark for endoscopic surgery-based treatment, which suggested that, like we saw in the beginning, overall survival and recurrence-free survival depends on histology. So it is a histology-driven treatment of cancer. The additional factors were involvement of the cranium, that is the brain, lateral and posterior lateral extension. So thus, extension eligibility for endoscopic resection was when it is limited to the medial, superior, and posterior wall, pterygopalatine fossa, infratemporal fossa, and the upper parapharyngeal extent. Contraindications to endoscopic resection essentially are invasion of the bony walls along the lateral, anterior, and inferiorly. Another easy way of understanding whether a tumor is amenable to endoscopic resection is to see the mid-pupillary line. By and large, all tumors which lie lateral to this mid-pupillary line need some sort of external approach as well. So what are the classifications we know of endoscopic resection? The very classical one is when it is pure endoscopic without any transgression to the skull base. When it is along with transnasal craniectomy, wherein we remove a part of the skull base, anterior skull base, along with, if needed, the dura, or maximally up to a part of the frontal lobe. Apart from that, there is a combined approach where coronal incision, frontal craniotomy, or subfrontal approach is considered along with endo-assisted, which is also called as an endo-assisted CFR. Now, once we have made a decision of open resection, as we all classically know the kind of incisions one may have to resort to for approach to the maxilla, beginning from the most conservative, that is the Moore's lateral rhinotomy approach, to the Weber, the second one being the Weber-Ferguson's, the third one being with the Lynch extension, when one needs to expose either the floor of the frontal sinus or the ethmoidal clearance. A subciliary extension when one needs to go far laterally to remove a part of the ITS, or encirclement of, or if one needs to do an orbital exentration along with the maxillectomy. Certain modifications need to be made in this incision depending upon the extent of lesion. Like, for example, this locally advanced post-NACT lesion where the anterior wall is breached and there is skin infiltration, where some sort of modification needs to be made to these incisions. Now, when the lesion is limited to the medial wall of the maxilla, one can safely perform a medial maxillectomy, either endoscopic or through the lateral rhinotomy approach. Typically, the infraorbital foramen forms a very important landmark to determine the extent of maxillectomy. The medial maxillectomy is limited laterally by the infraorbital foramen. Now, this Ongren's line, we all of us have read about it, that extending from the medial canthus to the angle of mandible, and it determines what an infrastructure versus a suprastructure maxillectomy is. Again, the infraorbital foramen forms a good landmark apart from the Ongren's line, wherein anything antero-inferior to the infraorbital foramen forms the infrastructure maxilla. Anything superior to that forms the suprastructure maxilla. Medially, the infrastructure maxilla also encompasses the inferior meatus and the inferior turbinate. So any lesion which is limited to the palate, the alveolar process of the maxilla, and with minimal extension into the sinus are suitable for an infrastructure maxillectomy. Gross extension into the sinus mandate a total maxillectomy. With an intact orbital floor would be a total maxillectomy. Anything which extends beyond that needs an extended maxillectomy encompassing either the orbital floor, infiltration into the orbit like we saw with involvement of the intraconal, that is involvement of the orbital contents, mandate an orbital exentration along with a maxillectomy. Now, coming on to the lymphatic spread, we know that the first echelon, particularly from the nasal floor, are into the cervical lymph nodes via the retropharyngeal or the parapharyngeal nodes. The first echelon into the cervical lymph nodes, particularly the submandibular nodes, is when the maxillary gingiva is involved. So largely, whenever there is a cervical lymphadenopathy, it portends a poorer prognostic marker for maxillary carcinomas, and that should be borne in mind. So this is all about what one needs to keep in mind as far as surgical planning is concerned with involvement of the maxillary sinus or maxillary tumors. Thank you very much.
So thank you so much, ma'am, for the wonderful lecture. And this was really nice because these are the topics which are often missed and nobody thinks about them, that how they're going to spread and how they're going to progress. So thank you once again for such an insightful talk. And I would request everyone to put their questions in the chat box, which we can discuss during the case presentation.
Thank you.
And I'll proceed to the next session now of the case presentation. And I'd like to request Dr. Mitali, madam, please join for the case presentation.
Sure.
The case will be presented by Dr. Gargi Dingani. She is a resident at Actrec, Mumbai. I'd like to invite the moderators, Dr. Shiv Kumar Thiagarajan. He's a professor of head neck surgery at Tata Memorial Hospital, Mumbai. Dr. Divya GM. She's professor and captain at Government Hospital, Kunnur. And Dr. Sambit Swarup Nanda. He's associate professor of radiation oncology at Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi. So he's here with us. So welcome you all. Gargi, you may start your presentation. Do we have everyone, all the examiners? Shiva sir. Dr. Shiva sir, are you there? Okay. Gargi, you can please start.
Good evening, sir. Good evening, ma'am. I'll start with my case presentation. So my patient is a 63-year-old male. He's a resident of Thane. He worked as a welder for 35 years and he retired 2 years ago. He presented to us with a chief complaints of loosening of the left upper tooth, followed by spontaneous fall of that tooth. And after that, he noticed a palatal ulcer, which has been there since 5 to 6 months. And he complains of dull aching pain over the left upper jaw and intermittent in nature, which was relieved with analgesics. The history of presenting illness. The patient was relatively asymptomatic 5 months ago when he noticed the loosening of a left upper tooth, which was followed by the spontaneous fall of that tooth subsequently. The patient noticed a palatal ulcer at the site of the fallen tooth and visited a local dentist for the same. The patient had a small ulcer to begin with, which progressed gradually to attain the current size. It is associated with burning sensation on eating spicy foods, and it is associated with left-sided dental pain, which was relieved by analgesics. There was no history of cheek swelling or loss of sensation over the cheek. There was no history of watering from the eyes, diplopia or decreased vision. There was no history of nasal blockage, halitosis, bleeding from the nose or headache. There was no history of decreased mouth opening or earache. There was no history of neck swelling, any other oral ulcer, and there was no history of excessive salivation, difficulty in chewing, difficulty in swallowing. There was no history of change in voice, difficulty in breathing. He did not have any history of weight loss, cough, blood in sputum, or bone pain. On past history, the patient had no other comorbidities or did not undergo any major surgeries in the past. There was no family history of malignancy. He has a mixed diet. He had a history of gutka consumption 4 to 5 times a day for the last 30 years, and he has been reformed since the last 4 months. There's no history of smoke, tobacco, or alcohol. On summarizing my history findings, my patient is a 63-year-old gentleman who was a welder who's now retired. He has a history of chewed tobacco addiction with no other comorbidities, presented with history of loosening and falling of the tooth, and a non-healing left palatal ulcer gradually increasing in size since 5 months. I'll move forward.
Yeah, Shiva here.
Yes, sir.
Hello, am I
Yes,
audible?
sir. Yes, sir. Yes, sir.
Yeah. So you asked a lot of negative histories. Can you just
Yes,
go back to that?
Yes, sir.
So, all right. So, no, one point I would like to make is that, okay, I mean, you just have to ask relevant negative histories, and some of it, might not be relevant. I mean, how would a history of bone pain be relevant in this? What is your intention in asking this question?
Sir, the weight loss, bone pain, blood and sputum was just for asking, finding out about metastasis, if there is any.
That's true. That's true. But
Yes,
then
sir.
it may not be accurate. I mean, so what I'm
Yes,
trying
sir.
to tell you here is that ask relevant negative histories. You cannot rule out everything, altogether in the history. The point here is the history taking should try to pick up certain subtle, findings which might otherwise be missed, certain subtle symptoms which might otherwise be missed, rather than just trying to rule out everything.
Yes, sir.
I,
Yes, sir.
just understand that point, right? I have
Uh,
no further questions. Yeah.
and so one question, and Dr. Divya, Dr.
Yes, ma'am.
Shiva, Azim, and so my question
Yeah.
is, Dr. Gaki, you said the history started with loosening and falling of tooth. Did he have any history of caries tooth or pain in that teeth region prior to that episode of
No, ma'am. Ma'am,
complaint?
no,
Uh,
ma'am. He did not have any pain. He just had a spontaneous loosening of tooth followed by the fall of tooth. After which he visited the dentist, and the pain came after the ulcer started growing in size.
Only after the falling of the tooth, he developed a pain.
Yes, ma'am. Yes, ma'am.
Okay, so you can tell that in the history there was no pre-existing, there is no history of any toothache or any history of any dental caries. He all of a sudden noted a loosening of teeth, and so that is important because he is a pan chewer. His orodental hygiene may be very much affected, so he is prone to get decayed or caries tooth and all. Okay,
Yes, ma'am.
yeah,
Yes.
that's one thing I have to add upon. Rest is okay.
The other
Doctor-
thing is, what is your intention of asking that to rule out history of diplopia and decreased vision? What are you trying to rule out, or
Sir,
why do you suspect this?
Sir, if there is a lesion that is involving the maxillary sinus and then moving to, involving the orbit or the extraocular muscles, he might have diplopia. And if it is going up all the way till the orbital apex, he might have decreased vision. Or if the optic nerve is involved, there might be decreased vision.
All right. So the point that we're trying to elicit here is if you keep giving a lot of negative histories, or even if you do give the relevant negative histories, you need to understand the basis of it, right?
Yes, sir. Yes, sir.
Yeah, that's the point. Yeah. Okay.
Dr.
I'll
Gargi,
move forward.
Dr. Gargi, Dr. Sambit here. So
Yes,
can
sir.
you go back to the negative history?
Yes, sir.
So what are you trying to elicit when we are asking about the excessive salivation?
Sir, if there is any involvement of the muscles of mastication.
So the more relevant question for that will be decreased in mouth opening, I guess.
Yes, sir.
That you have not asked mostly. Or is it there?
It says,
Okay,
She
so
said
the-
history of.
So whatever negative history you are asking, that should be more coherent with whatever your primary diagnosis you are expecting, depending upon the clinical history, the chief complaint and the presenting illness. So unless and until you are expecting a disease which is going into oropharynx or some part of the tongue or going into the palate also, in that situation you don't expect excessive salivation or difficulty in chewing. So you
Yes.
can avoid that in that situation.
yes, sir.
And one more thing here is there is loosening of teeth and falling. To look upon there is any antral connection, oro-antral connection, you can ask whether there is any nasal while he takes anything liquid, food and all, anything coming through the nose or any foul smelling through the nose and all. To rule out any oro-antral connection. Since you told that there is loosening of teeth and falling of teeth, there may be some connection with the maxillary antrum. Understood, Gargi? So
Yes.
that point also can be, you can mention upon there is no history of any food sticking on going into the maxillary antrum and causing foul smelling nasal discharge, or any while rinsing the mouth, the fluid coming through the liquid what is taking is coming out through the nose, to rule out any oro-antral connection. Okay.
Yes.
Yeah. Go ahead, Gargi. Go ahead with your findings. Examination.
Yes, sir. On general examination, the patient is ECOG 1, conscious, cooperative, averagely built and nourished. There's no pallor, icterus, cyanosis, clubbing. The vitals
Just a minute,
were in
Gargi.
the. Yes, sir.
Just kindly, present your history a bit more slowly. The way you're, saying it so fast, you'll be asked the same question 5-6 times. So rather just be a bit more slowly and say everything clearly. At present, you're telling it very fast.
Yes, sir.
I know we want to get done with this presentation, but
No, sir.
having said that, just be a bit more clear. Don't be so fast.
Yes.
Go ahead.
On local examination, on the intraoral local examination,
Yeah.
the mouth opening.
Go with the examination. Start.
Sir, your voice was breaking. Pardon, sir.
No, nothing. Go ahead with your
Yes, sir.
examination is what is being said.
Yes, sir. On local examination, the mouth opening was 3 finger breadth of 5 centimeters. Patient had good oral hygiene. He had tobacco stained teeth with missing teeth on the left upper alveolus. There was a slough covered ulceroproliferative lesion seen involving left palate and upper alveolus, approximately 4 into 3 centimeters. Medially, it was involving the midline. Laterally, it involves the upper gingivobuccal sulcus, but the buccal mucosa was free. On posteriorly, it was reaching the junction of the hard palate and the soft palate. Inferiorly, the retromolar trigone was free. The rest of the oral cavity subsides were normal, and there were no other ulcerative lesions seen in the rest of the oral cavity. On palpation of that ulcer, the inspectory findings were confirmed. There was induration palpable over the left upper alveolus and the palatal lesion. The lesion is non-tender on palpation, does not bleed on palpation, and buccal mucosa was free. The skin over the cheek was normal with normal sensation. Other subsets of oral cavity were normal. On external local examination, there was no ulcer or lesion on the cheek skin. There was no palpable induration of the cheek skin. There was no paresthesia. There was no pain or tenderness over the external skin. There was no palpable cervical lymph nodes. On examination of the orbit, there was no ptosis, proptosis, chemosis, no difficulty in extraocular muscle movement or diplopia. Bilateral visual acuity was normal. On local examination of the nose, on anterior rhinoscopy, the septum was midline and there was no polyp mass or lesion which was appreciated on anterior rhinoscopy. I went ahead with diagnostic nasal endoscopy, in which bilateral nasal endoscopy findings were normal. There was no mass or lesion seen involving the floor of the nose or the nasal cavity per se. On the examination of cranial nerves, there was no deficit elicited in any of the cranial nerves.
Now, Gargi, one question. Now, why do you have to present the cranial nerves separately here in this case?
Sir, if my lesion is involving the maxillary sinus, it might involve or any other sinuses or nasal cavity. It might end up involving the cranial nerves, sir.
But wouldn't that come within your central nervous system examination when you're doing that?
Yes, sir.
Would you, in an examination, present cranial nerves separately, and then would you not examine the central nervous system in a case of CA maxilla?
Yes.
That which is your suspicion? I'm not sure if that is the format. I mean, cranial nerve examination would come within the central nervous system examination, and especially if you're thinking in terms of anterior skull base lesions or maxilla. I know it's antero-inferior, but still, it will be
Yes.
part of the CNS examination. It cannot be presented like this separately. I think that's my opinion. Other examiners can opine.
Yeah, true, Shiva. It should be added on with the nervous system examination.
Yeah,
It
complete
is usually done like that, not separate cranial nerve examination. Along with the nervous system, you will tell these things and all.
Yes, ma'am.
So, Gargi, I think what needs to be done is you need to follow the regular format. You don't have to, do anything different from what you have done in the past,
Yes, sir.
Right. Go ahead.
On summarizing the history and examination, the patient is a 63-year-old gentleman who was a welder, now retired, with a history of tobacco addiction with no comorbidities, presenting with history of loosening and falling of tooth, non-healing ulcer 4 into 3 centimeters involving left upper alveolus, left palate, reaching the midline, posteriorly reaching the junction of hard and soft palate. The floor of nose and cheek skin were free, and there were no palpable neck nodes. My tentative clinical staging would be clinical T4A, N0,
Gargi,
and M0.
just a minute.
Yes.
Before this, now tell me, what is the epicenter of this disease?
The upper alveolus
it-
and hard palate, sir.
So, is it CA maxilla or is it CA oral cavity? Is my question.
So it is
Because
CA upper alveolus, sir.
it's not CA maxilla, right?
No, sir.
Okay. All right. Okay, so I mean, okay, go ahead.
So clinical staging was T4A, N0, M0. I'll move forward to the scans.
I understood it as, I mean, what was said was it's a presentation is of a CA maxilla, right? Hello?
Yes, sir.
Yeah, so the discussion becomes totally different now. So you're going to talk about CA, so the discussion is going to be that of CA oral cavity and not of CA maxilla. I mean, the other examiners can opine. I mean, we'll go ahead with this discussion, but I think the discussion will be like for a CA oral cavity, upper alveolus, hard
Yeah,
palate,
true. True. This
what
is more of a carcinoma of the upper alveolus. Management will the discussion will go with the oral cavity malignancy rather than a maxilla.
so
Totally agree, sir.
now okay, now you just present your findings
Yeah.
and let's keep the discussion to maxilla anyways.
Yeah.
I think the other examiners, if they
Yeah.
agree.
True. Okay.
Okay. So before you go into your imaging and all that, now let's presume that this is a CA maxilla, right? There's no ulceration in the hard palate and all that. Of course, there is loosening of teeth. And what is your staging? Let's say this is CA maxilla with loosening of teeth. You said nasal endoscopy. There is no lesion seen in the nasal cavity. So what would your stage be in that case for a CA maxilla?
Sir, in that case, sir, I would look for paresthesia of the cheek to find out if anterior wall is involved or not.
No. Now that there is loosening of teeth of the upper alveolus, you can give a tentative. So what do you understand? It's confined to the maxilla, right?
Yes, sir.
Do you agree
Yes,
with
sir.
that?
Yes, sir.
Okay.
Yes, sir.
So probably there's erosion of the floor of
Hard
the
palate.
maxilla,
So
right?
it would be a T2 maxillary tumor then, sir.
Erosion of the floor. What is T1 to? Just can you enumerate the staging for CA maxilla? T1 to
Sir,
T4.
T1 will be tumor limited to the maxillary cavity without any bone erosion. T2 will be a tumor that causes bone erosion of the hard palate or the medial wall, anything that does not involve the posterior wall or the pterygoid plates or skull base. T3 will be, yes, sir.
Yeah, go ahead.
T3 will be anything that involves the floor or the medial wall of the orbit, the pterygoid fossa, or the ethmoid sinuses. The anterior orbital contents are involved in T4A with the skin, pterygoid plates, infratemporal fossa. And
All right.
T4B will be orbital apex, dura, brain.
All right.
And nasopharynx.
So now, okay. So now, how would you go about? And you said neck. There is no palpable node, right?
Yes, sir.
Okay. So how would you go about evaluating this case now? What all will you do?
Sir, I'd like to do a biopsy if there is no visible lesion in nasal endoscopy. And I'd like to do CT. CT and MRI are actually complementary for sinonasal tumors, but I'd like to do CT first and get a basic mapping of the lesion and then go ahead with MRI if required.
So to get the tissue diagnosis, you said nasal endoscopy. There's no tissue that is there.
Yes,
How
sir.
will you get the biopsy
So
then?
if there is loosening of tooth and if the palatal erosion is there and if I can see an ulcerative lesion in the palate, I'll probably try and take a biopsy from there.
Okay. If that is also not there, what are the other options?
So guided biopsy can be attempted, sir.
Yes, image guided biopsy.
Yes, sir.
I mean, okay, you've done a biopsy, you've done imaging.
Yes, sir.
What else will you do? Would you do any evaluation to rule out distant metastasis?
So maxillary tumors will generally go, the commonest site of mets would be lung, then I'll get a NCCT of thorax to rule out lung mets.
What is the most common? Okay, the other examiners also can, I mean, if they have any questions, please go ahead.
So, Dr. Kargi, so what information will you get from the MRI that is not available with the CT scan?
Sir, MRI will help us delineate the invasion of the orbit, the involvement of the dura, any perineural invasion, if any, and involvement of infratemporal fossa and high infratemporal fossa will be better delineated on MRI, sir.
What about the skin involvement?
Yes, sir. Soft tissue delineation will be better with MRI.
What about the soft palate involvement extent of, because your disease was almost reaching up to the junction to some extent. What I think is induration might be going into soft palate region also.
Yes, sir. Yes.
So to delineate the extent of the disease in the soft palate region, will you prefer CT scan or MRI?
MRI, sir.
So what complementary information you will get from CT scan that you won't get from the MRI?
So the bone erosion will be better delineated on CT scan. So whatever bony walls of the maxilla will be involved or eroded, I'll find it better on CT, sir.
What about the secretions in the sinuses?
Sir, MRI will help us delineate between inspissated secretions and tumor, sir.
On which sequence of the MRI?
Sir, for secretions, T1 contrast, and on diffusion weighted, sir, we can differentiate inflammation versus tumor, sir.
T1 contrast for secretions.
Which sequence is better for differentiating secretion versus tumor? Of course, T1 contrast will tell the tumor, but then otherwise, sorry?
Gargi, please tell how will you different which sequence will be much more useful in differentiating in just both of the examiners were asking you which one
Yes,
will
sir.
be more informative.
Sir, sorry, ma'am. Ma'am, T2 hyperintense will be secretions, and tumor
Yes.
will be better seen on T1 contrast.
Okay.
So
You
that
said
is
diffusion
one.
weighted. Sorry, go ahead,
Diffusion
Divya. Sorry.
weighted to yes, yes.
Yeah, carry on. Go on, Gargi.
Diffusion weighted will differentiate between tumor and inflammation.
Only it will also tell you the density of cells, right?
Yes, sir. Yes, sir.
Whether, yeah. So that also is an important aspect of it. All right. Yeah.
One thing here, we're just repeating, in cyanodisal neoplasms, both CT and MRI are complementary, and whenever there is a middle meatal obstruction, when there is associated other sinus involvement, to differentiate between the exact disease and the anticipated secretion, MRI will give you more information, specifically when there is blockage to the frontal sinus and to the sphenoid sinus, the sphenoid recess and the frontal recess. So MRI will give you a clear picture whether it is a pucca tumor or it is an anticipated secretion. In that aspect, MRI is very much important, and a complementary give extra information with regard to the extent of the disease also. Okay, just repeating the thing and stressing on to that point. Carry on.
So now we have done the biopsy, have done the imaging CT, MRI, and NCCT thorax. When would you consider a PET scan and see a maxilla?
So PET scan is not routinely recommended for sinonasal tumors, sir. But
Yeah, that's why I asked, when
if
would
there
you
is a
consider?
very advanced tumor which is involving the orbital apex, or if it is going involving dura T4B lesions, I'll
So when the
suspect.
lesion is in the orbital apex, what is the question there? So that, what does that tell you? Why are you doing a PET scan when there is disease in the orbital apex?
It is enough.
Now, how will the PET scan help you in the decision making? Because you said when there's disease in the orbital apex, you'll do a PET scan. So how will the PET scan help you in the decision making process? So if there is no distant metastasis, you'll go ahead and operate. Is that what you're saying?
No, sir. No, sir.
Then how does it help? You said one of the indications is orbital apex there. So see, that's a wrong indication. You shouldn't be doing a
Yes.
PET scan for orbital apex, involvement. When there is orbital apex, the question is of operability. In that situation, you'll be doing an MRI
MRI. Yes.
to see to that whether whether the disease is going beyond the orbital apex. Is there a possibility of getting an R0 resection? So the questions are different there.
Yes, sir.
All right. So what are the other indications for PET scan?
Sir, if my histology is suggestive of mucosal melanoma or sinonasal undifferentiated
Correct.
tumor.
Correct. So
Yes.
it would
That
based
is
on the histopathology, right? If you have a high grade histopathology, can you tell some of the high grade histopathologies? You have named a few already,
So
wherein you will
sinonasal
consider.
undifferentiated carcinoma,
Okay.
sinonasal neuroendocrine carcinoma, mucosal melanoma, uh, adeno
Correct. Yes.
adenocarcinoma,
What are the types of adenocarcinomas?
intestinal type and non-intestinal type.
Correct. Okay. What are the
Keratocarcinoma
other
also.
Sorry?
I was just adding the list of teratocarcinoma also, sinonasal
Yeah.
teratocarcinoma.
Yeah. Sinonasal teratocarcinosarcoma. Yes, that is also another possibility. So, meaning to say, your PET scan indicate one of the indications is if you have a high grade, carcinoma in that situation, you would again consider a PET scan, right? You please have to understand as to when you will do a PET scan, and please don't say indications such as orbital apex as an indication for a PET scan. Meaning to say, you've made two mistakes there by not knowing what the actual indications are for a PET scan in CM maxilla and orbital apex. The further management for involvement of the orbital apex is also skewed there, right? So that way, you should be careful of what you're saying.
Yes, sir.
Okay. Which is the most common histopathology of the maxilla that
So
is commonly seen?
commonest is squamous cell, sir.
Correct. Can CM maxilla be involved by some metastatic disease from elsewhere? Is it a possibility?
Renal cell carcinoma, sir, and prostate.
Correct. So
Yes.
metastatic lesions also are a possibility. Renal cell carcinoma is one of them. CA breast. It can be
Breast,
anything, of
prostate.
course, but these are some of the described ones. Okay. Yeah. The other examiners, any other questions for her?
You also have to just keep an eye for nasopharyngeal carcinoma, which is presenting in this pattern with extension to the palate region, or plasmacytoma. Sometimes that is one of these are the two indications in which PET scan will be taken into account.
Yes.
Although rare, plasmacytoma in that location is rare, but it is not uncommon. It is seen.
All right. So what would you do next? You're done all PET, no distant metastasis. What's your further plan?
Sir, if the lesion is just involving the inferior wall of maxillary sinus and is located to the maxillary antrum, as we discussed, if it is a T2 squamous cell, then I would like to offer the patient multimodality therapy in the form of surgery followed by appropriate adjuvant therapy based on the histopathology. And in surgery, I'd like to do a partial maxillectomy with neck dissection and
Wait a minute.
repla-
Why do you say partial maxillectomy?
Sir, we'll be able to preserve the orbital floor, sir.
Do you have
Orbital
any
plate will be
images
preserved.
to display?
I have an
I mean,
image.
sorry. Okay.
Uh,
Okay. If it is involving the, message maxilla.
Let's see
Okay.
the
Samit,
images.
go ahead. Yeah.
Yeah, let's
Yeah.
see the images first. Sir.
yes.
Yeah. Sure.
So this is a craniocaudal contrast enhanced CT scan for the patient. There is no involvement of the nasal cavity, ethmoid sinuses. There's no involvement of the pterygomaxillary fissure, pterygopalatine fossa, or the lateral pterygoids appear free. The intratemporal fossa, there's no soft tissue enhancement. There's some secretions in the right maxillary sinus. There's heterogeneous enhancement of the right-sided upper alveolus and palate adjacent to it. There are no visible lymph nodes enlargement.
Do you have a coronal picture of it?
Yes, sir,
This?
I do.
Can you just show that, please?
Yes, sir. On coronal scan, there is erosion of the upper alveolus, but
Okay.
the lesion is confined
See,
to the upper alveolus itself. Yes, sir.
I think that's what. So I mean, it's skewed. I mean, this cannot be, it's like what is the type of maxillectomy that you'll do in this patient? I mean, let's
And
just discuss this picture and then go back again to the CM maxilla.
yes, sir. For this patient, since it is a midline involving lesion, our surgical cuts will cross the midline and it will be a Brown's type 2D maxillectomy where we'll be preserving the orbital floor, but we'll be removing the premaxilla and more than half of the heart palate. Sir.
And superiorly,
Superiorly, sir,
what will be
below the
preserved? What will be preserved?
infraorbital foramen will be preserving.
So it'll be more or less like a plate preserving maxillectomy, right? Orbital plate preserving maxillectomy.
Infrastructural, sir, because superiorly the disease is not extending more superiorly.
Okay, we would. Okay, we can discuss. I mean, yeah. Right. Can you just come anteriorly?
Yes, sir.
Okay, just go.
Yes, sir.
Okay, okay, I get your point. All right. So fine. All right. So now let's discuss as to what your cuts will be for a maxillectomy, right? What are the types of maxillectomy that you know of?
Sir, based on the Brown's classification, type 1 will be just an upper alveolectomy where there is no oro-antral connection. Type 2 will be maxillectomy where the orbital floor is preserved. Type 3 will be maxillectomy where the orbital floor is removed. Now, 3 can be with or without orbital exentration. Type 4 is where we're removing the orbital exentration and the total maxillectomy. Type 5 and 6 were added later. So type 5 is a orbitomaxillary removal where we're preserving the hard palate, but the orbit and maxillary walls are removed. And type 6 is nasomaxillary where we're removing the nasal walls and the medial walls of the maxilla.
See, what as I understand, the Brown's classification is the classification for the defect.
Yes,
Yes.
yes,
It doesn't
yes.
classify the type of maxillectomy.
Maxillectomy.
So this answer for the question is
Yes.
the type
Gaki,
of maxillectomy
you know
is.
what is Spiro's classification of maxillectomy? How Spiro classified maxillectomy into? Gaki, are you
Yes, ma'am.
am I
Yes, ma'am.
audible? Yeah.
Yes, ma'am. Yes, ma'am.
There's a Spiro classification which was modified by Cordero and Santa Maria.
I know the Cordero and Santa Maria classification.
Actually, can you tell the Cordero and Santa Maria classification?
Yes, ma'am.
Yeah.
Ma'am, Cordero and Santa Maria classification, type 1 was involving just one of the walls. So they had a 5-wall concept in
It's
maxillectomy.
actually classified into partial maxillectomy,
Yes, ma'am.
subtotal maxillectomy, total maxillectomy, again A and B with orbital
Yes.
exentration and
Yes,
without
ma'am.
orbital.
Yes, ma'am.
last one was the lately added, that is the orbitomaxillectomy, just like of that of the Brown's classification.
Yeah.
In the Spiro, there were only three: partial, subtotal, and the total. And Santa and Cordero and Santa Maria modified by adding the orbitomaxillectomy. So depending on the walls removed, depending on the number of walls of the maxilla removed, they classify the maxillectomy. The partial maxillectomy or limited maxillectomy means one or two walls is removed. Subtotal means you are preserving the what? In subtotal maxillectomy, 5 walls of the maxilla is removed, retaining the orbital floor. Total
Orbital floor.
maxillectomy, yeah. So 3 means all walls of the maxilla are removed, and that can be with orbital or without orbital excitation. And the last one was the orbital maxillectomy. So that is a Spiro, and the Spiros, there was no orbital maxillectomy, which was added on by the Cordero and Santa Maria. That was long back in 1997. Shiva, this is what you meant, asking about the classification of the maxillectomy?
Yeah. That's right. That's exactly what I was trying to ask. What are the types of maxillectomy, not the defect?
Yeah. Yeah.
So what we started explaining was the defect classification.
Sorry, sir.
Yeah.
What are the other defect classifications that you're aware of?
Sir, OK et al. Also had a defect classification.
So you need to be aware of all these.
Yes, sir.
All right. So please don't see, again, it all started probably you presented a case thinking it was of a CA hard palate. The case itself was not representative of what was supposed to be presented today. So I think that started all the, the thinking, thought process in your mind also has changed accordingly, right? So
Yes.
that's why it just, fell flat from the beginning. All right. So how would you reconstruct this patient? What will your
Since
reconstruction plan be? Oh, sorry, let's not go there further. Okay, you've mentioned what are the types of maxillectomy, the defect classification. Let's go to the neck and then go to the reconstruction, and then maybe Sambit can go ahead with adjuvant and all that. So, how do you manage the neck in this patient?
this
Not in this
patient,
patient, in CA maxilla. This patient is oral cavity, so we don't have much to discuss on the neck. You have to address the neck. Now,
Yes.
let's say, it's a case of CA maxilla. How would you manage the neck?
sir, for maxilla, there's a histology-driven approach, as ma'am talked about. So, if it is squamous cell, there is still a chance of occult nodal metastasis. So, I'd like to go ahead with selective neck dissection, even if neck is N0.
All right. Okay. Any the other examiners? Any questions for her on the neck?
What is the first echelon node of maxillary sinus malignancy? The first group nodes which are involved.
Yes, ma'am. There's anterior and posterior. So anteriorly, if the first echelon node will go to level 1B, submandibular nodes. Posteriorly, it will go to retropharyngeal nodes, and from there to the upper jugular nodes, ma'am.
Yeah. So in this patient, where is the location of the tumor? If it is a maxilla, supposing this is a maxillary lesion, we have to rule out any.
Sorry, ma'am.
Yeah. Continue. You continue.
Ma'am, it looks more anteriorly based since the pterygoid fossa and all is free, the posterior wall is free, then it would generally go to the submandibular lymph nodes, ma'am.
Now then, so it is always not a pakka anteriorly, not absolutely posterior. It comes almost in between, no, in your case?
Yes.
So does the prognosis change based on whether it is anterior or posterior?
Posteriorly, sir, if the pterygopalatine fossa or Widin canal is involved, then that will deem the tumor unresectable, sir.
Okay. So will that change the management of the neck?
Sir, posteriorly, the first echelon is retropharyngeal lymph node. So retropharyngeal will again deem it inoperable, sir.
So will you be able to address that surgically, retropharyngeal
No,
route?
no, sir.
So how will that change your outcome?
Sure. That no, it won't be surgically feasible. Then I'll have to send the patient for neoadjuvant chemotherapy or alternative treatment approaches, sir.
Okay, so post neoadjuvant treatment, if there is very good response, will that change your surgery, extent of surgery, and how will you manage the neck in that situation?
Post neoadjuvant, sir, the extent of surgery would not change, sir. I'd still like to go ahead with a selective neck dissection, sir.
Okay, so ipsilateral, bilateral.
Sir, it is a midline. So my patient is an upper alveolus lesion with midline abutment. So ideally, he would warrant a bilateral selective neck dissection, sir.
Or this patient would want a bilateral neck dissection, Gargi? Let's say your upper alveolus hard palate lesion, was it crossing the midline?
Sir, it was involving the midline, sir.
Okay.
Can we see the photo once? The clinical diagram?
Yes, sir.
So, may I make a point here? I think the message about management of the neck is not very clear. Shiva, could you just, summarize for the benefit of all the others here,
Yeah, I think,
yeah, please go ahead.
yeah, I do agree with you, Mitali, because I think the entire clinical picture, and even I'm not able to go back and forth from upper alveolus to CM maxilla. I'm also getting a bit confused. So I think the case has done the trick. But anyways, for CM maxilla, it's as you said, it's histology driven, the management of the neck. Like let's say if you have an adenocarcinoma or anything, or adenoid cystic carcinoma, which is also possible, you don't have to always address the neck, right? You will go with your clinical radiological assessment. If there's anything clinical radiologically positive, you would do the neck, or if you need to, go into the neck for purposes of, vascular access for reconstruction, that is when you would do the neck. So that will be your second indication. But let's say, come back to the most common histopathology, which is common cell carcinoma. So we have enough literature to say that the incidence of nodal metastasis from T2 onwards, T2, T3, T4 CM maxilla, the nodal metastasis goes upwards of 20%, even in T2. And that is to an extent even, correct for even upper alveolus. So in that situation, you would probably address the neck in a squamous cell carcinoma when it is T2 onwards, CM maxilla. If you plan reconstruction, then your management might differ, as I said. But otherwise, T3, T4, you would always address the neck, and also you might address neck for T2 because the incidence goes upwards of 20%. But this T2 upwards is a gray zone. But there are a few systematic reviews which have said that the incidence is quite significant and the chances of neck. So that's why many would consider a neck dissection even in a T2 maxilla. But for the rest of the histopathology, it would depend on the, if let's say, let's look at the high grade histopathology like SNUC SNUC or a sinonasal neuroendocrine carcinoma or, mucosal melanoma. All these cases, you would go with the clinical radiological assessment and do the neck, address the neck most of the time, right? But in my experience, most of the SNUCs, SNECs are, they present with retropharyngeal nodes and all that. So we're not talking in terms of upfront surgical disease. So it's not a very straightforward picture. That's what I would say. But I hope I was clear as to, in a clear-cut squamous cell carcinoma, CA maxilla, you would address the neck from T2 onwards, right? In clinical radiology and N0 neck. N plus, of course, you will go and address. N0, T2 onwards. Was that message clear, Mitali, Divya, and Samrit?
Yeah,
Or
yeah. So Shiva, one doubt. Suppose if we encounter any retropharyngeal lymph node in such a situation, how will we go with that?
That's why the clinical radiological assessment has to be spot on, especially when you have an ipsilateral neck node N plus. You have to always look, screen the neck systematically for any nodes in the retropharyngeal area.
Okay.
So
So
again,
that's precisely what I wanted to bring out, Shiva.
yeah,
The
yeah,
presence of cervical lymph nodes in a pure maxillary carcinoma by itself portends a poor prognosis.
prognosis,
That's
absolutely,
precisely what
Yeah.
I wanted to bring out.
Yeah.
absolutely.
Yes.
So,
Yes.
uh,
Agree.
so that is a poor prognosis, absolutely, without a doubt. The squamous cell carcinoma per se. So you need to systematically, evaluate the nodal stations in your imaging. But if your histopathology is something other than squamous cell carcinoma, and if there is a retropharyngeal node, you would probably, as you said, would go ahead with a neoadjuvant chemotherapy and see how the response is, and then go ahead with your surgical planning if that is based on the response. So if the question comes that if there was a retropharyngeal node and post NACT, if it has responded, would you still go in and clear that? The answer is surgically we would not be addressing the retropharyngeal if there is a good response. However, the adjuvant radiotherapy when it is being delivered, I think the retropharyngeal area would be
Lymph
in.
nodes should be covered.
Sorry.
No, if there is no if there is response when we are planning for an adjuvant RT, it should cover the retropharyngeal area too.
Exactly.
That is
But
what you are. Yeah.
yes, if for
Yeah.
example the retropharyngeal node does not respond, then probably the patient is not a surgical candidate if it is squamous cell carcinoma or any of
Yes.
the most of the high grade lesions, because it suggests a very poor prognosis in that situation. So you would not be considering the patient for surgery or doing a retropharyngeal node dissection in that situation.
Yes.
All right. There are very
Yes.
whenever there's N plus disease in CA maxilla, it's a poor prognosis, of course. But with that, you have to the possibility of retropharyngeal node also increases. So you need to systematically see that. But if it is retropharyngeal node is not there, but you have only neck node, the patient is. You have to treat the patient with curative intent, though the prognosis is not great. But what you need to understand is these patients might have retropharyngeal nodes, which should not be missed.
Yes.
That is the point that is being made.
Yes.
So that was the precise point that I want to emphasize when I was talking about the extent of the disease. When the disease is extending more posteriorly, the probability of retropharyngeal lymph node involvement increases significantly, and that changes the radiotherapy portals. So the extent up to which the nodes that we take into consideration, that changes. And suppose we get a situation where post NACT we don't get a good response, so patient doesn't become surgically operable. In that situation, patient will either go for definitive CTRT. Some people may argue about palliative therapy, but given the fact that most of the maxillary sinus only tumors with squamous cell carcinoma, not other variants, who, despite poor response to NSCT, patient tend to go to definitive CTRT, and the response rates are quite good. In that situation, we have to make sure that the retropharyngeal group of lymph nodes get a sufficient dose, that is up to 66 to 70 gray. And when we are going to that part, it is the part of the nasopharynx which get irradiated, and the toxicity consideration has to be taken into consideration.
Right. Yeah. So, Gargi, what you need to understand is the management of paranasal sinus tumors, and nasal cavity and paranasal sinus tumors. Now, this is CA maxilla. So, most common again is commercial. In most of the other paranasal sinus and nasal cavity is also commercial, but you have a wide range of histopathological varieties of malignancies that involve this area. And the management is histopathology driven. And there is no one straight clear answer.
Yes.
So your management will be based on your histopathology. That's what you need to understand. So your discussion for paranasal sinus, nasal cavity tumor, even for CA maxilla for that reason, is not the same like what you're going to deal with a CA upper alveolus or a
Yes.
hard pack lesion. So these are two different biologies. That's why they have different, staging system. Though even if they're squamous cell carcinoma, their behavior is different, the prognosis is different, and that's why they're being kept in two different stages are given for them, right?
Yes,
So
sir.
you
Yes,
need to understand that, and when you're presenting the case, you need to be very careful.
yes, sir.
You cannot present a case of CA upper alveolus and hard palate as a CA maxilla. That will not be accepted, right? Now, okay, we have discussed about the management of the neck and adjuvant, but then let's come back to the reconstruction. So, what would your how would you plan reconstruction for a maxillary defect? So that's where the Brown's classification comes into play again. So the classification is based on the defect that you have created and what are the options that they suggest. Go ahead.
Uh, So the resection will be, as I had mentioned, it will be a type 2D Brown's defect and will be losing a major chunk of the premaxilla, sir, since the cut will be crossing the midline at the palate, sir. So the best reconstruction for this patient would include bony free flap, sir. But I can either do a free fibula flap or a free soft
What are
tissue
all the
flap with a.
factors? What are all the factors you will consider while taking this decision for reconstruction of a maxillary defect? Understand my question well. What are the factors that will be
Yes,
taken
sir.
into consideration while planning for a maxillary defect reconstruction?
Yes, sir.
You can answer.
Uh, yes, sir. Sir, if the orbital plate is removed, I would like to support the orbit. If
No, you
there
just
is connection,
name the factors that you will consider. One is the plate, orbital plate, whether it's preserved or
orbital
removed.
plate, oro-nasal or oro-antral connection, sir.
Okay, that is a given, right? You're not going to have anything less than that most
Yes,
of the time, until unless we're talking about palatal fenestration.
yes, sir.
Now, in this defect, what are all the points you will consider? Now, see, you have to answer to the point. You cannot keep
Yes,
beating around the bush. Now, in this defect, you said it's crossing the midline and all that. Like that, what all factors you will take and say, like mouth opening. What is the mouth opening of this patient?
sir. This patient has good mouth opening, sir. 5
So, if the
centimeters.
patient had a trismus, a grade 3 trismus, would you still consider a fibula?
No, sir.
So, those are the factors that we are trying to elicit. So, start from there, go to the defect and the patient, factors as well, and then tell what are the options that you have based on the
Yes, sir.
defect, right?
Yes, sir. Sir, I will consider the dental status of the patient. I will
Exactly.
consider,
Yes.
yes, sir.
Ah,
Uh, yes, sir.
Go ahead. Go ahead. Very good.
So,
Go ahead.
oroantral defect, sir, if there is cutaneous defect, if any, if the supero-inferior extent of the defect, antro-posterior aspect of the defect,
Yeah. Okay.
uh,
Gyan Chand has to mute himself, or can you mute Gyan Chand? Someone? Yeah. Okay. So,
yes, sir.
yeah. What else will you consider?
Uh, Sir, the orbital floor, as we mentioned, sir.
You said yes. The
Yes,
other
sir.
important thing is whether the premaxilla is excised or not.
Yes, sir. The premaxilla. Yes, sir.
When the premaxilla is resected, then definitely a bony form of a reconstruction is, mandated more. So
Yes, sir.
what all
yes,
things you consider, as you said, is dentition of the patient, dental status, whether the dental patient is having teeth or edentulous,
yes,
mouth opening of the patient makes a huge difference. What is the various defects that you said, whether the floor of the orbit is preserved or not, whether of course, orbital exenteration, again, you would not consider a bone flap there, right? So all these, the skin, whether the skin is involved or not, again, that will make it may probably, make a difference in the choice of flap that you're going to do, right? So of course, based on the defect, there are certain options that are given as per the Brown's classification, but that's not all that is there, that is looked into. That gives you certain direction, but all these factors are not considered in the Brown's classification. So you need to look into that as well, right?
Yes, sir.
Yeah. Any other questions from the other examiners?
true. That this reconstruction part, these all factors has to be taken into mind.
Yeah. So, would you consider dental implant for this patient?
Yes, sir. Since he has inferior dentition, anterior implants can be done if we can give a fibula graft to this patient, sir.
Okay. So what is the evidence for that?
Sorry, sir.
It can be given, but the question is, should it be given? And why? Do you get my question, Gandhi?
Yes, sir. I understand, sir.
It can be given. I mean, you remove it and you give it. I mean, it's not as simple as that, right?
Yes, sir.
Again, whether the dental implant has to be given or not, you have to take various factors into consideration. Again, as was discussed, you have to say, you'll have to look at the dentition of the patient. If the patient has teeth, then there's a point in putting an implant. If the patient is edentalist, then that may be questionable indication.
Yes, sir.
What is the mouth opening of the patient?
Yes,
Whether the patient is motivated or not for a dental implant. How is the dental implant given? Why is this patient motivation impact important for a dental implant? Affordability of the patient again comes into play. Apart from affordability, what other aspect is important?
sir. The dental implants will require multiple visits, and it will be a staged procedure, sir.
Exactly. So even if you
And
give the dental implants free for the patient may not be motivated to come for multiple procedures down the line, right? You have to
yes, sir.
resurface the implant. You have to create the sulcus. So the
Yes,
patient is
sir.
may not, patient might require a local anesthesia or a general anesthesia. The patient may not be motivated to come every time for this, and then you have to load the artificial dentures onto it. So it takes multiple sittings. The patient has to be highly motivated for this. So one needs to understand these issues and not just give a blanket statement that I'll put dental implants. It's not that simple, right?
Yes.
Okay. Samit, I think we are at 6:50. Any questions on adjuvant or anything of that sort you want to ask her?
Yeah, so I would like to just ask, what about the adjuvant treatment? How will you take a call on what adjuvant treatment to be given to the patient?
Sir, for sinonasal, it will be histopathology driven, but sir, anything if it is commercial T2 and above, sir, adjuvant RT is recommended, sir.
So for T2 N0, you will consider for adjuvant RT?
Sir, the ESMO guidelines suggested for adjuvant RT for indicated in T2 tumors if uh, based on multidisciplinary discussion and patient wise. There was no specific indication for T2, but it was a gray area, sir.
Okay, so any other factors that will be taken into consideration while considering T2? Apart from T stage, any other thing?
The nodal,
Okay, so T1, N1 also you will take into consideration for RT.
yes, sir.
Let's just talk to the most common histopathology, it is commercial carcinoma. So anything
Yes, sir.
between T2, T3, T4, mostly T3, T4, but T2 is a gray zone. So T2,
Yes,
N0, you can or cannot give depending upon if the margins are clear. So what about the status of the margin? When will you call it as negative? When will you call it as positive? And does it change with the histopathology?
Yes, sir. Uh, the,
So
the
what is the
margins for
concept of margin in
yes, sir.
paranasal sinus and nasal cavity tumors? We're not talking
Yes,
about
sir.
oral cancers here.
Yes,
Now
sir. Yes, sir.
think
So,
for paranasal sinus and nasal cavity tumors and tell the answer.
so there is en bloc resection versus multi-block resection for margins, sir. We can send the margin for frozen section if multi-block resection is done. But
See, for these paranasal sinus tumors, the concepts of margins are debatable
yes, sir.
because for paranasal sinus tumors and nasal cavity, the concept of the margins in metrics is not given. It's one compartment ahead is the concept, right?
Yes,
You
sir.
So you just go one compartment, and if it is maxillary sinus and ethmoids is involved, you remove the maxilla and the ethmoid as much as possible on block, and then you go posteriorly to the posterior ethmoids of the sphenoids or the frontal sinus and clear everything. Go one compartment around and then clear it. Remove the periorbita if necessary and things like that. And of course, we have not asked you any question on management of the orbit in the maxilla. I don't think so. We have the time for that because we're almost at 6:55. So that is the other thing that you have to keep in mind. So it is one one compartment ahead. That is the concept of margins in paranasal sinus and nasal cavity tumors. You need to understand. Metrics is still not as crystal clear as it is in the other upper air digestive tract tumors. Right? Even there are a lot of controversies, but you have more data there compared to what you have here. Right?
Yes.
So when we look for the margin status, we don't look for that 5 mm, 3 mm, 2 mm in this situation. Specifically when the tumor is involving some of the foramens or if it is adenoid cystic, we just look at if it is R plus resection or not. Because that's how we take a call on the extent of the radiotherapy portals, radiotherapy fields. So
That's a great point that Samit makes. Samit, I'll just add to that.
yes, sir.
Is that adenocystic carcinoma is the only, histopathology in the paranasal sinus and nasal cavity tumors where an R plus resection is acceptable. As
Yes.
of today. You can get an R1 resection that is good enough. Even an R2 at times may be okay. But R1 is definitely acceptable and adjuvant radiotherapy is given. But other histopathologies and R plus resection in the paranasal sinus and the nasal cavity tumors is not accepted. It's just like any other upper air digestive tract tumor, squamous cell carcinoma. So that point you need to have in mind. Go ahead, Samit. Thanks.
So whenever you get the histopathology, you have to sit in the multidisciplinary panel and there you take a call. If it is adenoid cystic and the surgeon is saying that just R plus resection might be a situation, you go ahead, but not in every case. In other cases, it may not ultimately lead to a good outcome. So if we get a R2 resection or R1 resection, if in case of squamous cell carcinoma or in case of SNUC, the outcome is pretty bad. SNUC at such is, even with R0 resection, the outcome is not very good.
Right. I think we are closing at 7. Can we just, is it okay if we wind up, Samit, Divya, Mitali?
Yeah,
Yes,
sure.
sir. Yes,
Yes,
sure.
sir.
Yeah. Sunaina, I think we
Yeah,
can.
I'm there.
Yeah, see,
Okay.
sorry.
Yeah. So
Can we
thank
wind
you,
up now?
everyone. Anybody would like to make any final comments or suggestions for Gargi?
I think I would say, Gargi, when you're presenting it, you have to present the right case. You know the facts for sure,
So for the
but I
case,
think,
I'll ask for, I'll just please pardon me because she said she did not have a maxilla, so I said it's okay to present her upper elders.
okay. No, because the question, even I was finding it a bit, I was taken away from what to ask what, so I was a bit confused too myself.
Yeah,
So,
true.
otherwise, she answered most of the questions. I think
Yeah.
because of this confusion, she was also held back. So keep
Yes.
reading, Nadi. All the best.
Yeah. All the
Thank you,
best,
sir.
Gargi.
Thank you,
All the
ma'am.
best,
Thanks so
Gargi.
much.
Yeah. Yeah.
All the best, sir.
So thank
Thank you,
you
sir.
everyone.
Thank you,
Thank you,
sir.
Dr.
Thank you, ma'am.
Mitali for joining, and thank you, Shiva sir, Dr. Divya, and Sambit for joining today, and thank you, Gargi, for the presentation. And
Thank you,
thank you
sir.
all for joining. Shall see you once again on 23rd of October.